A, B, C, D, E, F, G, H, I. Oh, hello, Dr. Leibert here. Chest X-ray interpretation. We're going to do the ABC method. It's right in front of you. A is for airway. B is for bones. C is for cardiac shadow. D for diaphragm. E for effusion. F for free air. G gastric bubble. H hilum. I interstitium. It provides a systematic way of looking at chest x-rays so that you can learn to identify normal and abnormal. And that way, you'll be much more comfortable if you do this every time with every chest x-ray that you have. Okay, let's look first at the normal chest x-ray. A, airway. There's the main stem bronchus. Just follow my arrow. There's the right main stem, the left main stem at the carina, where they break into right and left sides. Airway looks all right. B is for bones. Here are the bones. What I'd like to do is just walk along that nice curvilinear rib markings to make sure there's no step-off suggestive of a rib fracture. Take a quick look at the scapula, the clavicles, and at those sternoclavicular junction. If those are asymmetric, that you know then the patient is rotated. And that will change the markings of the right and left side of the lungs. So we've done A, B. Let's talk C, the cardiac shadow. First we'll go down that right side where the superior vena cava comes in. There's the right atrium and ventricle. Then on the left side, the left ventricle, left atrium, the aortic knob. And right here, the aortal pulmonary window. You don't see the typical notch or the window here quite as much. This is an older patient whose aorta is a little calcified. A, B, C, D. We want to look for the diaphragms. We'll go down here. The diaphragm looks good on both sides, nice and rounded. Of course, the right side's higher because of the liver. E is for effusion. Look at that costal phrenic angle. There's no evidence of fluid there. G, gastric bubble, little air there, gastric area. H for the hilum. That's where you see the pulmonary vasculature. So there's pulmonary vessels, pulmonary markings. Look at that. That's a vessel end on. Has a nice homogeneous look to it. And then I is the interstitium. And that's the actual markings of the lung that go from the hilum out to the ribs. What I'd like to do is compare the right and left sides. A lot of times I'll take my hand and just cover the heart shadow so I compare the right and the left. It brings out abnormalities. Then we go over to the lateral side. I'd like to look at the sternum. The retrosternal area should be radiolucent. Then the heart itself, the very important retrocardiac space, and then the vertebral bodies as they come down. You should see them nice and clearly. And then the diaphragms. There's that right side, a little higher than the left diaphragm. Very nice. Now, the 6 danger areas. I want to really encourage you. After you've looked at your PA, you've looked at the lateral, go back and one last time, check on the 6 danger areas. The 2 apices, the tips of the lungs, 1, 2. The aortal pulmonary window, 3, the 2 costal phrenic angles, 4, 5, and the retrocardiac area, 6. These 6 areas are where bad things tend to hide. Infiltrates, tumors, TB. Okay, let's talk about a patient who presents, this 42-year-old presenting with rust-colored sputum, fever, and cough. Airway looks nice and straight. And the bones look good. C, the cardiac shadow is a little fuzzy here on the right side. Looks pretty good on the left. D, the diaphragms, again a little obscured here on the left. No obvious effusions. No free air. Gastric bubble is here. The hilum look okay. But on the interstitium, when you compare the right to the left, notice on the right side there's these markings that are obscuring the right heart border, and then you have these markings obscuring the left diaphragm. Oh, interesting. Let's look at the lateral side. Here's the sternum, the retrosternal area looks okay. The heart looks okay. A little thick here because we've got, an infiltrate the right middle lobe. There's the retrocardiac area, not too bad. Until we get here. Look down here by the diaphragm. It's obscured the diaphragm because there is a left lower lobe pneumonia. So we're losing that left diaphragm. The patient has both the right middle lobe, obscuring that heart border on the right, and the left lower lobe pneumonia, both infiltrates. Here's a patient who presents with a fever, weight loss, night sweats, and some hemoptysis, bloody sputum. The airway is a bit pulled to the right. The bones look fine, cardiac shadow looks fine, diaphragms look good. There's no effusions, no free air, gastric bubble is present. And the hilum looks okay, but look at the interstitium. Look at that massive infiltrate here in the right upper lobe. This patient has pneumonia. Has tuberculosis in the right upper lobe. What proved that? Well, of course, the AFB sputum proved that. Tuberculosis loves the apices, or the tips of the lung, where there's the most oxygen. TB loves high oxygen concentrated areas. Now here's a patient. Let's go right to the interstitium, because all the rest is pretty good. But up here in that left upper lobe, look at this asymmetry. This patient had a squamous cell cancer in the lung. Look at that apex. Not good. So the left upper lobe mass turned out to be squamous cell cancer. Now here's a 40-year-old alcoholic who presents with a seizure to the emergency department and now has fever. You notice now his airway is a little curved, but the reason is, look at the bones. He is turned or tilted to the right. And the reason for that is he's not terribly cooperative. So he is turned to the right side, on his right side somewhat. And so it gives you a little asymmetry between the left underexposed side and the right overexposed side of the lung. So we realize that's there. The cardiac shadow is a little fuzzy on both sides. Diaphragm, a little, certainly we can't find it on the left. And if you look in those angles, the angles are gone. There's an effusion on the left, an effusion on the right side also. There's no free air, gastric bubble you can't see. The hilum is somewhat obscured. Look at that interstitium. Big markings infiltrate here. The right lower lobe. We look over here on the lateral and look as you come down. The retrocardiac area is totally shot. There's infiltrate obscuring the retrocardiac area and covering the vertebral bodies. He has an aspiration pneumonia, which loves to go down that straight shot, down the right main stem bronchus. Interesting. Aspiration pneumonia. Here's a patient. This is a 50-year-old smoker presenting with fever and cough. It's been going on for about a month. Airway looks okay. The bones, patient's turned a little bit to the right. Not too bad. Cardiac shadow looks good. Diaphragms look okay. There's no effusions, no free air, gastric bubble we can't see. The hilar markings are good, but look at this. Wow. Again, the right lower lobe, how can I tell? Because see how it brings out, silhouettes that right heart border. There's a big infiltrate there, big pneumonia, or a lobar, a right lower lobe, lobar pneumonia in this patient. Boy, here's a 71-year-old male who presents with severe shortness of breath and hypoxia. He's very low on oxygen. Pardon me, the slides have a little mind of their own here. Airway is very straight, very interesting. Scarring does that. The bones look okay. Cardiac shadow is very fuzzy because of all the scarring around it. Diaphragms also have some fuzziness. There's no effusions, no free air, the good gastric bubble. The hilum, too, is kind of covered up by the interstitium. This is primary pulmonary fibrosis or idiopathic pulmonary fibrosis in a patient. who was very near the end of his life. And you see the scarring of all that fibrotic change. Now he also has a pacemaker, and notice that this pacemaker is dual chambered. There is a lead in both the right and left ventricle. Now this is a COPD patient. I want you to see it because it shows the hyperinflated lung and the somewhat flattened diaphragms of patients with chronic obstructive pulmonary disease. And notice on the lateral the wide barrel chest. Whoa, big old barrel chest, that patient with obstructive disease, so they can breathe in, but they have trouble getting the air out, so air traps cause them to be big blue bloaters. Now here's a patient who presents with shortness of breath and respiratory failure. This is pulmonary edema. I want you to see the pattern, these bat wings, if you will, of pulmonary edema fluid in the alveoli, in the interstitium. And this is pulmonary edema. Notice that the diaphragms are spared. There's no effusion, but it's the interstitium that's just clouded with pulmonary edema. Now this is a little one, presents with cough, wheezing, shortness of breath, hypoxemia. You get a lot for your money with an X-ray of a child. The airway itself looks good. It looks patent. I don't see any evidence of croup. With croup, you'd see what's called a steeple sign, a very narrow area of the trachea, way at the top of the airway. Bones look good. Cardiac shadow looks normal. Diaphragms are somewhat flattened. The patient is somewhat hyperinflated from all the tachypnea. There's no effusions, no free air. There's some air in the gastric bubble and lots of air swallowing. Look at the whole intestines filled with air from this poor kid doing all the fast breathing he's been doing. Interstitium looks okay. You still see some thymus. Notice a little widening of the mediastinum. Now this child is about 6 months old, so there's thymus shadow. It's called the sail sign. That thymus will shrink down in the anterior mediastinum soon enough, but in that first year of life or so, you'll see that wide mediastinum from the thymus shadow. There's no obvious infiltrate, but notice in the interstitium, this is an air bronchogram. This patient has bronchiolitis caused by respiratory syncytial virus, RSV, and this is called an air bronchogram. What it represents is fluid around a hollow tube. And so in an air bronchogram, you see that dark space of the bronchiole surrounded by the radiodense water, if you will, the edema from the virus. Okay, that's an air bronchogram. They also have some parabronchial cuffing. And notice little donuts here where there's fluid around the airways. Those are called air bronchograms. This is a patient with a large effusion, the E. Look at this on the left side. There's an air fluid level right there. Big effusion caused by a cancer that's caused sweating, if you will, into the pleural space. Big pleural effusion. Now here's a patient who presents after a motor vehicle accident with shortness of breath. This patient has a pneumothorax. The arrows show you where the lung is collapsed. So the lung, which used to be out here, is now collapsed in to this little ball. You'll have to have a chest tube placed to re-expand that lung. This is a pneumothorax. And here's another picture of a pretty amazing pneumothorax on the right side. And all you get is this little bit of lung tissue to get a chest tube in there, re-expand that lung. So we've explored the airway, A, B, the bronchioles, or the bones, C, the cardiac shadow, D, the diaphragm, E, effusions, F, free air, G, gastric bubble, H, hilum, and I, interstitium, looking at and interpreting the chest x-ray. So, enjoy your day, get out there, look at those chest x-rays, get some practice with it. God bless you.